So I'm going to demonstrate the clinical examination of shoulder and the knee joint related to the instability and the soft tissue injuries. So before we proceed for any clinical examination, we should know the thorough history of the patient. In history, mean the name, age of the patient, occupation of the patient, chief complaints, mode of injury, and the date of injury. So this is a patient, a 42-year-old male, farmer by occupation, has a history of injury to the left knee, that is twisting type injury, which is history of fall from the bike 3 months back. His chief complaints is pain and instability of the knee joint. So now clinical examination, proper clinical examination, the inspection. So in inspection, we should expose the patient from the mid thigh to the full foot, and we should compare the normal side to the abnormal side. Here on inspection, I can check there is a wasting of muscle of the mid thigh, mainly the VMO muscle wasting. There is no any deformity of the knee joint. I have compared on the normal side. Usually here in any ligament injury, we should check for any fixed flexion deformities there or not. There is no any scar, no any obvious swelling on the knee joint. Now the proper palpation. So it is as a standard, we should compare on the normal side and then the abnormal side. So in palpation, we should check for the temperature. Here temperature is normal. Then we check for the tenderness. So in knee joint, tenderness point are medial joint line, I think the best thing is you can go on the opposite side. So you'll be able to demonstrate also, and you will not come with you. So in palpation, I should check for the medial joint line. So I proceed from the proximal part of tibia, that is bone part, and we check, we reach till the joint line. So here is the medial joint line. I can check the patient face. He is not having any tenderness on the medial joint line. The same thing on the lateral joint line. He is not having any tenderness, the lateral joint line too. Then in palpation, I check the tenderness at the attachment of the medial collateral ligament on the femoral side, that is the medial epicondyle, lateral epicondyle, and the lateral epicondyle. He is not having any tenderness at that area. Is also I check the tenderness at the attachment of the medial collateral on tibial side and the fibula side. Now in palpation, I should check for is there any effusion or not. So in effusion, we usually check for the patella tap. So in patella tap, I squeeze the suprapatellar pouch. Then I check the patellar thrust. This patient is not having any effusion. Better. That's the palpation. Then I proceed for the range of motions. So active range of motion and passive. जी slowly इसको bend करो, bend और करो, yes, सीधा करो. So there's active range of motion. Here you can see the patient is having the full range of motion. Then passive range of motion. So he's not having any deformity and range of motion are full. Now in special test, so patients test for the instability and any ligament injury or meniscus injury. So in patient's test, first test, I will do the Latchman test. So before doing the abnormal side, you should always check for the normal side and then the abnormal side. So Latchman test, which is test for the cruciate ligaments, the anterior cruciate ligament tear. That is fine, sir. Hello. So in latchman test, you should fix the thigh with one hand, and with, so this will be better. Hello. Okay. So here I can, so I should fix the thigh with one hand and hold the tibia, proximal part of tibia in other hand, and check for the instability. So I have fixed the proximal thigh with hand, and I'm checking for the anterior translation of the tibia with the 10-degree flexion of the knee joint. So here you can see there is significant anterior translation of the tibia. And simultaneously in latchman test, we should check for the end point, whether the end point is hard or soft. Here I can feel the end point is soft. Okay. This fine? Okay. Yeah. So we should keep the knee between the 15-degree and the 5-degree, that is about 10-degree, and we should fix the thigh with one hand, that is distal part of thigh, and with other hand make it loose, completely loose. Ask patient to make relax, completely loose हो जाए आप, ठीक है? आपको कुछ नहीं करना है, एकदम रिलैक्स लेटना है, बस मेरे को करना है सब। लूज छोड़िए, पूरा लूज छोड़िए, रिलैक्स, या आपको कुछ नहीं करना, रिलैक्स छोड़ो, ढीला छोड़िए, बस ढीला छोड़िए सर, बिल्कुल रिलैक्स। हाँ, आपको कुछ नहीं करना है, आपको कुछ नहीं करना है, रिलैक्स हो जाए। Then check for the, so here I can see that the anterior translation of the tibia and the hard point is soft and mushy. That's latchman test. Then second test is anterior door test. Ask patient to flex the knee, thigh in a 45-degree and the knee in a 90-degree. And we should fix the foot by sitting on the foot of the patient. Check for, and put your thumb on the anterior joint line. Ask patient to relax and check for any hamstring laxity or there or not. Pura loose chhudiye aap, relax, and check for anti-translation of the tibia. So before doing the test, we should always check on the normal side and then abnormal side. Relax chhudiye. So in anterior door test, before proceed for the proper anterior door test, we should check for whether there is any posterior slag of tibia is there or not. So how to check the posterior slag? Ask patient to keep thigh in 45-degree and 90-degree, relax, and put your both thumb on anterior middle joint line. So normally there is a 1 centimeter step up of the middle tibial plateau or the medial condyle of the femur, and in posterior cruciate ligament tear, this step up go away. So that's a posterior slag. So it should not be, it will not mislead as a anterior cruciate ligament tear. This is a common mistake that happens from the examiner. So here we can check there is no any posterior slag. And I have done the antidote test. It's positive in this patient. Here we can check. The next test for the anterior cruciate ligament instability is a pivot shift test. The knee in a full extension. We hold the foot. एकदम relax होना है आपको. We do the rental rotation of the foot. एकदम आपको relax होना है सर, ना बिल्कुल. एकदम आपको कुछ नहीं करना है, relax हो जाइए. So internal rotation of the foot. Then I keep the one hand, the right hand on the proximal part of the tibia, and I will give the whole stress, and slowly I will flex the knee. Relax छोड़िए. हाँ बिल्कुल बिल्कुल relax छोड़िए. Yeah. आपको कुछ नहीं करना है, बिल्कुल relax होना है. Yeah. Sir, here I am doing the. आपको कुछ नहीं करना है सर. Relax छोड़िए, बिल्कुल relax. Yeah. Yeah. So full internal rotation of the foot, then hold the stress on proximal tibia, and I will slowly flex the knee and extend it. Here I can see that foot shift is positive, but is not so significantly positive. So mild posterior translation of tibia or the femur. Here what happened? When we flex the knee from extension, the IT band get relaxed and the tibia will be posteriorly displaced. That is positive if it is anterior cruciate ligament tear, and it is more significantly positive when there is a lateral complex tear is also there or associated with the meniscus injury.
Rajeev, can we go for shoulder now? Last.
Yes, sir. I will just finish one test.
Yes, just faster.
Now, second test is the posterior cruciate ligament test. It is same as the anterior cruciate ligament. Where we fix the foot with one hand, put thumb on opposite hand, and we try to check the posterior translation is there or not. That is a posterior cruciate ligament test. The other test for the posterior cruciate ligament is a active quadriceps test, where we ask patient to flex the thigh in 45 degree and knee in a 90 degree, and we ask patient to do the active quadriceps contraction. If it is posterior slack, this tibia will translate anteriorly if there is a posterior cruciate ligament here. Then last test, pull up port cable ho jaye. That is dial test. Here we check the external rotation of the foot in 45 degree and 90 degree. एकदम relax हो रही है. So normally when there is no only 15 degree external rotation of the foot, and we compare the abnormal side or normal side, when more than 10 degree external rotation of the abnormal side, it suggests that there is a posterior PLC injury or posterolateral instability. And if same thing happens in 90 degree also, it suggests that there is posterior cruciate ligament tear plus posterior lateral instability. So test is positive only in a 30 degree, that is a posterolateral instability. If it is positive in both 90 degree and the 45 degree, it suggests that posterior cruciate ligament tear plus posterolateral cord instability. सीधा हो जाइए. So that's done the knee examination, mainly related for the instability and the posterior corner soft tissue injury around the knee joint. So any knee joint examination with incomplete without examination the popliteal fossa, one joint proximal, one joint distal, and the neurovascular status. Yes. Yeah. Now I proceed to the case of shoulder. So I will demonstrate the common test related for the shoulder instability and the impingement. Shut carbon. Yes, sir. कोणता हात आहे ना? ठीक आहे, वर सरकून बसा. So after taking the full history, we should go for the proper examination. So I will directly proceed for the examination. So in inspection, so in first sentence, I will tell that the examination finding of shoulder is not so conclusive as compared to the other joint like knee joint, because there are a lot of structures which are close to each other. So tests are overlaid with the other pathologies. So in inspection, we should check the inspection whether both shoulder at the same level or not. We should check for any swelling, is any scar, old scar, or any sinuses. Then we proceed for the palpation, standard protocol palpation for the temperature check. Then we should check for the tenderness. So most commonly tenderness which we see at the AC joint, whether patient is having tenderness at the AC joint or not. So we palpate the clavicle from the middle side and go slowly go to the lateral side, and we check the spine of the scapula. And here is the angle which is formed between the spine of scapula and the clavicle, that is a 45 angle, that's correlate to the AC joint. And here I can check the tenderness. He is not having any tenderness at the AC joint. The second point for checking the tenderness is the anterior joint tenderness and the posterior joint tenderness. Tenderness at the greater tuberosity. That's a tenderness. Then we should check for the range of motion, active range of motion and passive range of motion. Stand नीचे हो जाइए. Yes, हाँ. हाथ ऊपर करायचे तुम्हाला. हो. उठला. So I am checking the active abduction. उठला. Maximum. Yeah. Maximum. Here I can check there is restrictions of the abduction to more than 100 degree. Yeah. खाली या. Then we check the internal rotation, external rotation. असा हात ठेवायचा. आतमध्ये घ्यायचा आणि बाहेर घ्यायचा. अच्छा. घ्या आतमध्ये घ्या. आणि बाहेर घ्या. त्या साईडला घ्या. असं. खाली घ्या. Yes. वर घ्या. The active external rotation and internal rotation. खाली ठेवा. समोर उचलायचं, पाठीमागे घ्यायचं. Forward flexion and maximum. मागे घ्या. And the flexion and extension. So abduction, adduction, internal rotation, external rotation, flexion and extension. Now I do the passive range of motion. So to check any abduction, we should fix the scapula with one hand and then do the slowly abduction. So I can check he's having the abduction up to the 90 degree. And we should check whether movements are painful at extreme or not. He's having the pain at the extreme abduction. Then I will check the external rotation, internal rotation. So keep the shoulder up to the 90 degree, and check for external rotation and internal rotation. So he's having the restriction of internal rotation and pain at the extreme level. That's the passive range of motion. Then we check for the forward flexion and the extension. Now I will proceed for the spatial test. So spatial test mainly divided for impingement test and tendinosis and for checking the stability, and for checking the strength of the rotator cuffs. So in impingement test, I will demonstrate the near impingement test, where I fix the scapula with one hand and I slowly do the passive elevation of the shoulder, and I will check whether he's having any impingement pain or not. He's not having any impingement pain, we can check. So that is knee impingement test, which usually positive in adhesive capsulitis, supraspinal tendinitis, and it can be even positive in a Banker's lesion also. So it's not so specific for the rotator cuff, but we can check whether there is impingement of shoulder that is a supraspinal rotator cuff, and whether the patient is having the bursitis or not. Then we check. I will do the Hawkins Kennedy test. Relax. So 90 degree of the abduction of the shoulder. Ask patient to relax. And I will do the passive sudden internal rotation. That is Hawkins Kennedy test. Which also check the impingement. The next impingement test is a subcoracoid impingement, where we do the elevation up to the 40 degree and we do the internal rotation and we check whether he's having the pain out there or not. He's not having pain at the coronoid impingement. Then I will check the test for the bicep tendinitis. That is speed test. असं धरायचं. मी वर उचलला तुम्ही खाली दाबायचं. वर उचला, लावा हात. Pain. So you can check here, he's having the pain that suggests the patient is having the bicep tendinitis. That's a speed test. Then second test for the bicep tendinitis is a supination test. So 90 degree of the elbow flexion and pronate the palm and ask patient to do the supination against the resistance. He is also having the pain in the supination against the resistance. That suggests that patient is having the bicipital tendinitis. Then I will do the test for the integrity of the rotator cuff. Then I will check first of all the strength of external rotator. So this is test for the checking for the whether the patient is having the strength at external rotation or not. That's it. Then I will check for the lift off test and I will do the belly press test. पोटाला जोरात दाबायचं. ओके, हे सगळं ठेवायचं समोर. असं हात इथे ठेवा, बस ह्याला पोट दाबायचे, दाबा. So what I in belly press test, ask patient to press the belly with the palm. So normally the shoulder never goes beyond the trunk, but here you can check. Press kara. So here shoulder is elbow is going back to the trunk. That suggests that patient is a weakness in the subscapularis. So this patient is having the subscapular steer. That's why we can check he's doing the pressing the belly with the help of the shoulder. Then second test is lift off test. For the subscapularis, that is internal rotators. हात असं ठेवायचं. हे हात आहे ना पाठीमागे असं हे करायचं. ओके, हा करा, ट्राय करा. So I am asking you to lift his hand back above his back, but he's not able to do it. That lift off test is positive because this patient is having the interrotator tear, that is subscapular tear. Ultava. Then we should check for the drop arm sign. So we abduct the shoulder up to the 45 degree and we hold his hand with one hand and suddenly lift it. So normally in drop off sign, this will drop like this and it's positive in the external rotator tear. Here we can check patient is able to hold his leg even against the resistance of the gravity. So drop arm sign is negative. That's fine, sir. There's some test for the instability. I'm not going to deep inside it, but one test I will demonstrate, that is aberration test. That you should know to everyone. So in aberration test, what we check, we do a test in a 45 degree and the 90 degree. So we do the external rotation and we try to dislocate or give the anterior pressure to the shoulder. In the aberration test, this patient will say there is pain and we will catch you. That's positive in 45 degree and 90 degree, depending on the severity of the Banker's lesion and Hinge-like region. That's done from common test done for the instability, impingement, and the tear.